So now we are going to study about ADH, that is anti-diuretic hormone. That means it causes antidiuresis, মানে it reabsorbs free water. Its another name is vasopressin, means it causes vasoconstriction. It is produced from supraoptic nucleus of hypothalamus from the magnocellular neurons. From the magnocellular neurons. So what is being produced? The substance which is produced is pre-pro-arginine vasopressin. Pre-pro-arginine vasopressin. It divides into neurohypophysin, hypophysin 2, ADH and copeptine. What stimulates the secretion? Increased osmolarity. That is equal to 2 into Na plus glucose by 18 plus 1 by 2.8. This is detected by the supraoptic nucleus and it secretes ADH and also increased osmolarity causes increased ADH secretion and also increased thirst. So free water is absorbed from the kidney, reducing its loss, and free water is taken in by the thirst center orally. So the ADH can also be stimulated by decreased ECF volume. Decreased ECF volume also causes increased ADH secretion. So there are 4 receptors of ADH: V1A, V1B, V3 and V2. How do these act? V1A acts by vasoconstriction. Its secondary messenger is phospholipase C and then calcium. It causes vasoconstriction. V2 secondary messenger is CAMP. Okay. and V2 has another effect, that is on von Willebrand factor. It increases von Willebrand factor and increases platelet adhesion. Therefore, it is used in many emergencies where upper GI bleed or intractable bleed is occurring from nose or some other mucosal bleed. So, platelet adhesion. And V1B and V3 increases ACTH secretion. Okay, from anterior pituitary. So V2 by CAMP causes increased aquaporin 2 expression on the apical luminal side of PCT. Okay, so this is the cell of PCT. This is the luminal side. This is the basolateral side. Here is the ADH receptor. What is the receptor? V2 receptor. This causes increase in CAMP. This causes expression of aquaporin 2. This causes reabsorption of H2O. Here aquaporin 3 and 4 reabsorbs H2O. So reabsorption of H2O is occurring. In normal cases, we do not need ADH. Normally ADH is not present because it is only secreted when there is increased osmolarity. Okay, when there is increased osmolarity, then only, or decreased ECA volume, then only this is secreted. Normally our PCT reabsorption is isotonic. मतलब water with solute is absorbed. Okay, and water with solute is absorbed and solute reabsorption in max this is 85%, and THAL and DCT solute reabsorption occurs this solute reabsorption may cause increased sodium. Okay, that may result in this osmolarity. This can be stopped by, and normally a person drinks water less than 15 liter per day. Drinking water. If a person drinks more than 15 liter per day, then ADH is stimulated, and ADH is not stimulated, ADH falls, and the fall of ADH causes release of the excess water. Other than this condition, ADH is present very low. Here it is, if it is less than 15, then it is low, and if it is more than 15, then it is not present, nil. Okay. So in case of psychogenic polydipsia, there will be decreased ADH. Okay. And now we come to the clinical features of if there is increased ADH. If there is increased ADH, when does ADH increase? Normally, ADH will increase if there is osmolality is high. Then it will help. If osmolarity is not high or ECF volume is not low, then if ADH increases, then what will happen? Then water will accumulate, and increasing water will decrease the osmolarity. Relative osmolarity will decrease and there will be dilutional hyponatremia. Sodium will decrease. Okay. So what are the clinical features of low sodium? Normal is 135 to 145. This is normal. If it is from 130 to 134, then the patient will have mild GIT symptoms, that is nausea, vomiting, mild. If it is 120 to 129, then they will have moderate GIT symptoms, moderately present, and there will be lethargy. Means CNS is getting started to involve. Is starting to get involved. Okay. And from 100 to 119, it is going to cause CNS symptoms. And less than 100, the volume will be so high that it will result in increased ICT symptoms. Okay, this is severe. This needs 3% NaCl correction. So below 120, it needs 3% NaCl correction per day 8 milligram correction. Okay. So when we are getting this sodium low, then we can have either pseudo hyponatremia. This is hyponatremia. Okay. We can give pseudo hyponatremia, euvolemic hyponatremia, or hypovolemic hyponatremia. So if it is a pseudo hyponatremia, that means it is actually that sodium is not less, it is dilutional hyponatremia. Why can it happen? It can happen because of increased effective solute. Effective solute is increased. That is what? Mannitol, glucose, glycine, maltose. These will extract water from intracellular space to extracellular space. So effective solute increases H2O. That is why there is pseudohyponatremia. Other causes can be triglyceride increase, that is hypertriglyceridemia, or paraproteinemia. Some proteins which will draw water but not result in osmolarity. Okay, so euvolemic is what? The ECF volume is normal. There is no ECF volume loss. ECM volume loss is not there. The causes can be hypothyroidism, hypocortisolism, and SIADH. Okay. And hypovolemic can be due to decreased ECF volume. Decreased ECF volume is resulting in increased H2O absorption by ADH. By ADH and so these two cases there will be increased ADH in hyponatremia, euvolemic hyponatremia and hypovolemic hyponatremia. So how are we going to differentiate between this euvolemic and hypovolemic? This hypovolemic is appropriate because it is supposedly that decreased ECF volume requires increased ADH secretion for reabsorption of water. So this is appropriate. This is decreased ECF volume. The decreased ECF volume can be due to ECF due to GI বা renal বা third space loss. This is hypovolemic. And if it is because of water accumulation in the intracellular space, then that is because of CCF or CHF or cirrhosis, then it is hypervolemia. But both of the cases ECF volume is less. In one case it is just lost from the body, and in another case, that is hypervolemia, the fluid is shifting from normally ECF is this and ICF is this, and then it is getting shifted. Okay, ICF collection is increasing. So effectively the total volume is increasing. Hypervolemic. So in inappropriate SIADH, in inappropriate ADH secretion, the volume is euvolemic. There is no change in volume. But then still, and the osmolarity is getting modulated because of the ADH. So there is a resultant, that is not the stimulator. So what are the causes of SIADH? One is trauma. Another is paraneoplastic syndrome. Mostly SCC lung, small cell carcinoma lung, small cell. Okay, and then drugs. Drugs are 5C, chlorpropamide, clofibrate, chlorpromazine, carbamazepine, and cyclophosphamide. Other than this, drugs that can cause is NSAID, TCA, SSRI, vincristine, oxytocin, and nicotine. Other causes may be acute meningitis, meningoencephalitis, basically, acute meningoencephalitis, acute intermittent porphyria, acute necrotizing pneumonia, and multiple sclerosis. These are the causes. So what happens if ADH is more? What is the clinical feature of SIADH? ADH secretion is more, water reabsorption is more, serum sodium is low. What about urine sodium? Urine sodium will be what? Serum sodium is low. Water is more reabsorbed. What it should have been? It is more reabsorbed. But sodium is not. So, urine sodium will be more. Right. Urine sodium will be more. That is more than 20 milliequivalent per liter. If urine sodium is more, what about urine osmolality? Urine osmolarity will be more. Okay. And what about serum osmolarity? Serum osmolarity will be low. And there should be no other issue like hypothyroidism or hypocortisolism. So, but here we are saying that water is getting absorbed. Water is getting absorbed. But still euvolemia. How euvolemia? How still volume maintained? Volume is maintained because atrial natriuretic peptide, okay, brain natriuretic peptide, and RAS all are causing excretion of sodium and water more. So this is causing more decrease in sodium. Okay, for maintaining the volume, this is happening. Okay, RAS will do what? Aldosterone. Aldosterone will increase sodium and decrease potassium. And decrease K plus, H plus. So, these will decrease sodium, aldosterone will increase sodium. Okay. Aldosterone will do this, But when the volume is increasing, on increasing volume, what will happen? This will increase, this will increase, but RAS will do what? RAS will decrease. Increasing volume, increasing pressure will deactivate RAS. So, sodium is going to increase more, decrease more. It is going to result in more hyponatremia. Okay. So, what is the treatment? Here, what is the treatment? Treatment is fluid restriction. Just restrict the fluid. Okay. And you can give Vaptans if it is a chronic ADH. If it is a chronic SIDH, you can give Vaptans. So now coming to decreased ADH. Okay, decreased ADH is manifested by what? Decreased ADH is manifested by what? So, decreased ADH. ADH is antidiuretic hormone. Decreased age is decrease in antidiuresis, that is increase in diuresis. Increase in diuresis means polyuria. So, this is how the patient will present. So, if what is polyuria? Firstly, what is polyuria? 3 liter per day or 40 ml per kg per day. 40 ml per kg per day. More than this, if urine output is more than this, then it is called polyuria. First approach is we will check the osmolarity of urine, because diuresis can be two types. One is solute diuresis, another is water diuresis. Solute diuresis is because of diabetes. How will we see? More than 600 milliosmol, specific gravity more than 1.020. In water diuresis, increased ADH can be a cause. It can be psychogenic, means drinking more water, urinating more, okay, and it can be psychogenic, or it can be due to not increased ADH, due to decreased ADH, okay, or due to ADH resistance. Okay. These two are known as diabetes insipidus. We are coming to it, it's okay. Here the urine osmolarity will be less than 300 milliosmol and specific gravity will be less than 1.010, and the water excreted per day will be 7 liter per day. Okay, it can be as max as 7 liter per day. And if it is diabetes insipidus and not psychogenic, how will we differentiate this? Diabetes insipidus will have decreased urine osmolality and increased plasma osmolality. So water diuresis আবার আমি সেরাম অসমোলারিটি ভাবছি, সেরাম অসমোলারিটি। ওকে, serum osmolarity, if it is more then DI, if it is serum osmolarity is less then it is psychogenic. Okay, urine specific gravity is low but not fixed. It is fixed in case of CKD, but it is low and it is variable. So coming to diabetes insipidus. DI. DI can be divided into central and nephrogenic. What is central? Decreased ADH. It is also known as AVPD, decrease deficiency, and this is due to AVP resistance. This is deficiency, this is resistance. The most common cause is stroke effect, and another cause can be pregnancy, another cause can be genetic. In case of genetic, it can be autosomal dominant, which is most common. It can be autosomal recessive and it can be X-linked recessive. The autosomal recessive form is also known as DIDMO-AD. DI, DM, optic atrophy, deafness, optic atrophy, and DI and DM. Okay, this is known as the Wolfram syndrome. The Wolfram syndrome. Okay, how is this diagnosed? This is diagnosed if we have seen that during secretion of ADH, three things are secreted. Okay, copeptin, ADH, and neurohypophysin 2. If copeptin is less, then we know the secretion is less. So we will measure copeptin. Okay, so copeptin levels will be less than 21.4. If we do arginine stimulation assay, this is going to decrease more. Copeptin will decrease more. So what is the treatment here? Treatment is the same thing we studied earlier: intranasal or oral desmopressin, so intranasal is taken BD, oral is taken OD. This is 10 microgram to 20 microgram, and this is 0.1 to 0.8 nanogram. Okay, now going to nephrogenic. Nephrogenic can be due to fibrosis of the kidney, that is CTID. This can be due to IgG4, sarcoid, or Sjogren. Nephrogenic DI can be caused by all these CTID, then fibrosis, nephrogenic DI. Drugs can cause, most importantly, lithium, cisplatin, denulocycline, and forcin. Dyselectrolemia, calcium increase, uric acid increase, oxalic acid increase, mutation in aquaporin 2, or potassium lake. Vasa recta occlusion by sickle cell anemia. Here in the diagnosis, copeptide will be more than 21.4. And here the treatment is thiazide. Thiazide is a loop diuretic. It will increase the sodium, it will decrease the sodium reabsorption and cause and in lithium induced, it is amiloride. On trampoline. This will excrete sodium and water. Sodium will be excreted. The serum osmolality is increasing now. That will be neutralized. Okay. And in this approach, if there is hyponatremia, we'll also again see serum osmolarity. If serum osmolarity is normal, then it is pseudo. If serum osmolarity is decreased, then it is euvolemic or hypovolemic. ECF volume decreased. And among hypovolemic, it is again two types. That it is ECF hypovolemic and whole body hypovolemic, or just only ECF volemic but actually hypervolemic. So, and in this we need to rule out diuretics and psychogenic. Because diuretics also causes hyponatremia, and psychogenic increase water uptake will also cause dilution, and diuretics will decrease sodium, decrease water, increase potassium, especially thyroid. Just the opposite for this action only, it is used here as a treatment. Here it is used as the treatment.